round of introductions, and we have a few people coming in late, but we're so thrilled to have a crowd of 56 people who've RSVP'd for this first kickoff meeting of the season to learn from each other about how to save more lives. That's what it gets down to, and that's why it's exciting to come together month after month since July 2012 with this group, and since February 2010 in our original group in San Diego. So today is a very, very exciting day where we are going to have a speaker with us who will be formally introduced right before she speaks, but I want to say that she embodies the Right Care Triangle. When we started the Right Care Initiative, we had gathered best practices statewide for years, and we created the synthesis that you see on the Right Care Triangle, that the apex of which is the activation of patients, and the other two critical corners are the use of medication protocols and the use of care teams. And I think we all know what the dream is, and it's pretty well represented in the Right Care Triangle that you see on the back of your handout. But there is only one, there are very few people in the state, I think, that have kind of lived it and accomplished it. And for that, Ray Bogany from San Diego, Dr. Ray Bogany, received the first ever Platinum Award combined with Leadership Award, because what she did was she took a medical group that was performing last in the Southern California Kaiser region, and she worked tirelessly with her partner from pharmacy, Yvonne Plowman, to use unblinded data to raise the scores such that now San Diego Kaiser has reached the national A grade of performance across every single metric for heart attack and stroke prevention, diabetes. So and with that, I will ask that we go around the room and introduce ourselves, because it really is something that requires everyone coming together and supporting each other and mentoring each other. And I think that Ray can testify that that's what happened in San Diego. She couldn't have done it by herself, and nobody can do it by themselves. So in the spirit of collaborating and teamwork, Chad, would you start with Dr. David Eibling?
Hi, I'm David Eibling. I'm the new medical director at Molina.
Nancy England. I'm one of the pharmacists at Blue Shield, specifically with our ACOs.
John Berglund, California Health Collaborative.
If everyone would speak up, please, we cannot hear you.
I'm Martha Yardy. I work for Health, and I represent health education for Northern California, and am the lead in the state for cardiovascular health for my health fund, for health education.
And I'm Heidi Ransom, the clinical pharmacy coordinator for Southern Health.
I'm Alicia Ye. I'm a pharmacy student on rotation right now with Heidi.
Juanita Riveros with California Rural Legal Assistance Foundation.
Yvette Crossell, I'm at California State College of Pharmacy.
We did not hear that. Would you please repeat that?
I'm sorry. Yvette Crossell, I'm the director of the experiential program for California North State College of Pharmacy.
Great, thanks for being here.
Thanks for having me.
Hi, Colleen King, Senior Program Officer here at the state.
Hello, Diane Littlefield, Vice President of Programs, Sierra Health Foundation.
Chad Vargas, Health Services Advisory Group.
Kristen Robinson, I'm the CCMG for Kaiser North Valley.
What is that?
CCMG for Kaiser North Valley.
CCMG stands for?
Chronic Conditions Management.
Thank you.
Olivia Custiri, sorry? Olivia Custiri, Public Health Officer for Sacramento.
Cassiere for being with us. I don't think many people heard that, but Dr. Olivia Cassiere is the public health officer for the region.
Hi, I'm Jennifer Wykowski, State Program Director of Health Services Advisory Group.
Matt Lincoln, Medication Safety Task Lead for Health Services Advisory Group.
Elaine Lynn, Prescription Future Medication Adherence Awareness Campaign.
My name is Mick Smith. I'm the Regional Director of the American Heart American Stroke Association for our Daily Guidelines programs.
Warren Barnes, UC Berkeley School of Public Health, Grace Presbyterian Church in Sacramento.
Hi, Larry Von Rodriguez, Sacramento County Public Health, and I currently am overseeing our chronic disease program, which includes the Supplemental Nutrition Assistance Program, also known as SNAP-Ed, and a new grant that we received from California Department of Public Health, the Prevention First, to address chronic diseases.
Good afternoon, I'm Sarah Brass. I'm the Special Assistant to the Chief of Staff for the VA Northern California Healthcare System.
Good afternoon to everyone. I'm Beth Abbott. I'm the brand newly minted Director of the Office of the Patient Advocate. And for those of you who have no idea what that is, we are people that bring you report cards on health plans across the state and over 200 medical groups based on both clinical data and patient experience data. And I'm the former regional administrator with the Centers for Medicare and Medicaid Services and CMS for Region 9. And I'm pleased to be with you.
Don Forster, physician with First Aid and expert in chronic disease reversal.
Jim Ellsworth, Executive Director of Capital Health Network.
Margie Knox, I'm the State of the UC Berkeley School of Public Health.
Marilyn Stebbins, UC San Francisco School of Pharmacy.
Lisa Ashton, UC San School of Pharmacy.
Jessica Nunez de Varna, California Department of Public Health, responsible for California Wellness Plan implementation.
John Hartman, I'm the Stroke Director at Kaiser Sacramento.
I'm Charlotte Parker, and I'm a practice coach for several organizations in the region.
Hi, I'm a physical therapist.
I'm Doug Robertson. I'm the Regional Director for Hill Physicians in the Sacramento market.
Hi, I'm Betsy Thompson. I'm the Deputy Regional Health Administrator for Region 9, so we represent the Office of the Assistant Secretary for Health, and I know many of you from my last position as the Chief Medical Officer for CMS in Region 9.
Hi, I'm Gil Simon. I'm the Medical Director and Founder of Sacramento Family Medical Clinics in Sacramento.
Jerry Chappie, California Chronic Care Coalition.
Bill Remack, California Chronic Care Coalition, Chairman of the California Hepatitis C Task Force, and Right Care Initiative volunteer cameraman.
I'm Mary Ferguson, Chief Medical Officer of the Health Services Advisory Group. Good afternoon, everyone. I'm Dr. Ray Bogany from Kaiser Permanente SCPMG in San Diego. Proud to be here in Sacramento for my first time ever.
I'm Alan Vaughn, the CLO of the First Medical Group in Sacramento.
You all know me, and now I will turn it up. I'm Hattie Hanley, Right Care Initiative, Department of Managed Health Care, and UC Berkeley School of Public Health. And now I'm going to turn over the podium to our longtime co-chair, Dr. Arevalo, who is the Chief Medical Officer for Sutter Independent Practice Association. And he's going to talk about a vision for a roadmap for hypertension control for the Sacramento region.
Thank you, Hattie, and again, thank you all for being with us. And we're really excited that we're continuing with 2015 and your participation because, again, it's about collaboration around improving cardiovascular risk reduction for our region. And so, in that vein, what what we wanted to talk about, and I'm going to talk more in generalities because it's really about the follow-up, whether we do this or not, because it takes a commitment. But what I wanted to share with you is at least a recommendation that the Planning Committee has discussed around developing a roadmap for hypertension, what we typically call guidelines of development. And what I wanted to share with you is just a basic background around why we think that this might be an important sort of product. And I'm calling it a product because, you know, as you know, one of the things that we've been doing for the past 2 years is bringing you together, bringing key discussants like Ray to talk to us about some of the things that they've done so that we can learn. It's about collaboration and best practices with the hope that we can move forward with you know, activities around what we've learned and taking it home and eventually, you know, creating interventions that can assist the patients that we serve. So one of the things that this is about is the idea of creating a product, and the product would be, we believe, around hypertension guidelines. And there's some controversy. It's not necessarily, yeah, let's do that. And so I'm going to just touch on a couple of things as we have this conversation to eventually come up with a discussion of should we do this or not, because again, it's really about you out there and what you'd like to do as kind of a next step in the development of right care. So basically, what guidelines, and I'm not going to go into details about, you know, what we're talking about in terms of guidelines or what we want to consider roadmaps. And really it's, you know, doctors and other healthcare professionals rely on scientific literature, and in addition to their knowledge as well as experience and patient preferences to inform their clinical decisions. Clinical practice guidelines or roadmaps or whatever you might want to call these recommendations, I don't think it's necessarily that, you know, there's one term that fits what we're talking about, but in fact, these are all statements that include recommendations intended to optimize patient care. They're informed by usually, and again, I'm talking about the ideal guidelines, are informed by a systematic review of evidence and an assessment of the benefits and harms of alternative care options. Because there are a large number of clinical guidelines that are out there, depending on which area, and, but because there's so many, then a lot of times it is confusing to the average practitioner. And one of the things we need to consider is who is our target audience for these recommendations, because I think that's really going to be a key concept in the development and the promulgation of these recommendations. And so, you know, many times the users find it a little bit confusing because it's coming from all sorts of places. And so what happens essentially is sometimes, unfortunately, they're not really looked into and at times ignored because of the various, you know, places that this is coming from. And so it actually becomes a lost leader to sending one extra guideline out there, unless, of course, it's really accepted by a large number of individuals that or organizations or institutions that, you know, the target audience has accepted, then you have a higher likelihood of the acceptance of these recommendations. So if the users had an immediate process to identify the quality, the trustworthiness, and it would help them with their decision making and potentially improve the health care that they're providing. So, you know, it is a recommendation. It's an analysis and reformation. And again, this is base case scenario. It's aimed at a target audience, and it's done in such a way where the practitioner can really determine the usefulness of, you know, diagnostic tests, procedures, or treatments, so that it's not 25 pages of guidelines. It's succinct, and it sort of addresses the key issues of the target audience. So that's an ideal guidelines. What I wanted to really focus on is what guidelines are not, because I think that's where we get confused and where there's a pushback sometimes about developing these recommendations. And what they are not is a standard of care. So although people believe that guidelines are a standard of care, they may be used in the development of standard of care, but by itself, a guideline, as we say, is a roadmap. And when you look at a roadmap, you're here and you want to get there, and there's a variety of ways to get there. And a good roadmap really will tell you what is an efficient way to get to that process. But you can also find a whole bunch of other roads that will get you to the same place. And so it's the way to do something, but it's really not the only way. And also the other key piece that we sometimes get into confusion is that guideline is not necessarily a liability for the organization that's developing, as long as you develop a formal process that is defensible in terms of the recommendations that you found. And so you can't just willy-willy introduce general concepts. So, but it's certainly not a liability, and I don't believe that any organization has ever been sued with some result of having liability by producing a well-done, well-researched, and evidence-based guideline. So I think that's one of the key pieces and the key messages that we wanted to kind of provide for. As we talk about the possibility of what we call capital region right care hypertension guidelines or roadmaps or whatever term you want to use. And again, the other key piece is that clinicians are free to use these. They can take it or reject it. They can take pieces of it. One of the beauties of guidelines is that you can actually, if they're done well, you have the references behind your recommendations, and individuals can use those references for their benefit as well, and can support the recommendations that they're making to improve care. But I wanted to just briefly talk about, Joan Werblin and I went through this, when was it, Joan? 2004 or 2005? No, 2004. Yeah. We developed diabetes care guidelines for California, basic diabetes care guidelines. We went through this whole process, and we worked with the Diabetes Control Program of California. This is through the Diabetes Coalition, and eventually we created guidelines that were actually aimed at primary care doctors primarily and patients that produced some really excellent tools that were used after the fact, still are being used, by the way, by the Diabetes Coalition in California to empower patients, actually taking recommendations to their doctor and saying, hey, could you check off the states when I got these, and actually led to some really great stories. So I think it really, there are some benefits to coming up with and biting the bullet to creating guidelines. Now this is from a slide from the Institute of Medicine, and as you can see, it's a whole process. I don't want to bore you with this, but to develop our own guidelines, I think, would be onerous and would be outside of the resources that we have. So we're not saying that Right Care develop our own guidelines and go through a process that we went through with the Diabetes Coalition, which was very, very extensive, and we revised it every single year. But what we wanted to recommend is that we would not reinvent the wheel. We could review and select from pre-published and accepted guidelines, either Measure Up, Pressure Down, Million Hearts Campaign, maybe locally from Sutter, Mercy, or others. And the other recommendation is that we select one of these as our Right Care Initiative guidelines, not multiple, because unfortunately we run into that same problem when you have multiple guidelines that are competing, even if it comes from one organization, then it can be confusing. And that this would be the first Right Care Initiative Sacramento or capital-based product that we could sort of hang our hat behind, and that would help us move forward with the next steps about improving hypertension management in the region. So that's what I wanted to share with you. What we wanted to do at the end of this session is get your thoughts and get your recommendations and see, should we go through this process, and we could then discuss how we might be able to do to eventually arrive at these Capital Region Right Care Initiative hypertension guidelines. Thank you. So what I'd like to do now, as you think about that, is really introduce Alan Erdl, who's our co-chair, who has done a marvelous job of assessing, because I think it's helpful to understand what the clinicians think about these things, and he's going to help us with some of the work that he's done through Mercy Medical Group. Alan?
Well, thank you for having me, and thanks for allowing me to talk today. I'm not sure when my presentation went to, but Well, one of the things I'm sure of is I don't know what I don't know, and therefore I ask a lot of questions. And part of what I try to do is make sure that what I'm going to implement actually has a chance of working. Because you kind of need to know where the doctors are coming from before you can run down a path that may or may not work. And so in our previous discussions, we were wondering what to do with a guideline or a roadmap or what to do. And so what I wanted to do is take the pulse of some of our doctors. And so I developed this survey. This is my survey. It's all my fault. And the questions are worded the way I worded them. And you can take it or leave it, or what I did is I sent it out to all of our primary care physicians. We got about 29 responses, which is about 45%. And so it's probably representative, although you have to be careful about saying that, particularly in an unvalidated instrument, and that's what this is. So the first question I asked was for adults younger than the age of 60 years old, what is the appropriate target? To try to assess what is their knowledge base. So, based on JNCA, what's the right answer? You have to participate, that's the rule.
Less than 140 over 90.
140 over 90 is correct. Systolic at 140 and diastolic at 90, that is correct. So most of our physicians were pretty good. And then for an older population, over the age of 60, what's the appropriate goal for based on JNCA?
150 over 90.
150 over 90 is correct. So you can see that our physicians, and we'll get to a question later on, they feel pretty confident in their knowledge. Their knowledge is not perfect. What about for those over the age of 80? JNC doesn't directly address this, but there are other places that do. Right. It's higher in general. 150 over 90, probably. And I've seen that published in various places, so you have to be more and more careful because, again, part of what we do is do no harm. And the tighter you try to treat some people over the age of 80, you're more likely to cause them to faint and fall and have hip fractures, which is worse. What percentage of your patients in each age group do you estimate to have appropriate blood pressure control? I'll go to the table that's a little bit more informative than this, but you can see that in general, between 50 and 74% on average is where people think that they have their population controlled. And you can see the spread of how various folks answer this question. So anywhere from 25 to 49%, even lower than that for one answer, and above 75% for a number of them. I think that that's probably wishful thinking. So what are the and again, this is assessing physicians' understanding and knowledge of where they're at. What's the lifestyle changes do you recommend for hypertensive patients? Smoking cessation 100%, exercise 100%, weight loss, improved diet, reduce alcohol consumption. That's actually a very important guideline to reduce alcohol consumption because that certainly drives a lot of hypertension in the United States. What proportion of your patients are able to control their hypertension recommendations with lifestyle changes alone? The vast majority said less than 25%, which is probably correct. So then, again, more assessing physicians' knowledge. What's your first-line antihypertensive agents for non-African American people who are under the age of 60 years of age? Actually, this should be for everybody, not just under 60 years of age. So, what are the appropriate answers? What are the first-line drugs?
Diuretics.
Diuretics. Calcium channel blockers. ACE inhibitors. And ARBs. That's right. Those four are the first line. So now, and I think that they did a reasonably well there. I think there are people that maybe from when I trained that are using some of the other ones that were first-line therapies a long time ago. And your first-line antihypertensive agents for African-American people, again, it should be of any age. What are the correct recommendations based on JNCA? Diuretics.
It's hard to read it. Can you just read out what it says on the...
Thiazide-like diuretics, calcium channel blockers, ACE inhibitors, ARBs, beta blockers, renin inhibitors, alpha blockers, and on down. So there are really only two. It's thiazides and calcium channel blockers. So again, pretty good. Second-line antihypertensive agents really are only beta blockers and aldosterone antagonists and maybe some others. And then everything else becomes third line. And reasonably good at pinpointing those. So a lot of people are on combinations. They use a lot of combinations, ACE and thiazides. And that's one of the recommendations is the next step. If you don't control them on your first shot, increase the dose, add a second drug, particularly the first line drugs. What percentage of your patients are on combination therapy? A very large number, as it turns out. So probably based on this, at least on average 50% more. Do you normally recommend patients acquire home blood pressure monitoring? The answer is yes, 75% of the time. What percentage of patients do you think have home blood pressure monitoring device? Less than 50%-ish. And of those patients with a home blood pressure monitoring device, what percentage do you feel use it? And again, it's mediocre at best. Have you heard of measure pressure down? Nope, for the most part. 4 Million Hearts campaign, even less. And this, again, we have a fairly informed group, right? So, what are the biggest impediments to achieving blood pressure control? And they throw this right back in the laps of patients. So, let's go to the table, it's easier to read. Patient medication adherence, motivation to taking medications. 90% of people said that that's a primary driver. Patient medication adherence, financial, less of a problem because of generics. Patient willingness to make lifestyle changes, very highly ranked by this cohort. Then lack of home blood pressure monitoring, and then lack of ability, lack of availability of home blood pressure monitoring. I think I put that in there twice. They answered it the same way, surprisingly. That was pretty good. That's internal validity. Although you shouldn't ask it the same way. Do you feel that medical assistants at MMG have training and experience to consistently do it? About 85% maybe. So again, I suspect it's probably lower than that, significantly. Do you feel that a better approach to achieving excellent blood pressure control for a primary care partner might work with a Coumadin type of team protocol? And they said, in general, for uncomplicated hypertension, at least 50% said yes. Key question. Do you feel you have enough knowledge and training to care for the majority of hypertensive patients? 100%.
Of course, they're physicians.
So again, I'm starting to know what I didn't know before. On a day-to-day basis, in the care of your hypertensive patients, how often do you refer to a guideline? Less than 20%, there's probably 50% of the people, and then intermittently, and some over 80%, which is really quite good. If you use a treatment guideline or protocol for hypertension, which you use, JNC of various types, 6, 7, 8, was listed the most frequent, and then others, which actually refer to JNC. So this gives insight into at least some of the physicians in our group of how they think about hypertension, uncomplicated hypertension, not in diabetic patients. And it provides the ability to start saying, what do we need to do as far as moving our group down the road to better control? And part of it is that they have knowledge gaps and need to do certain things better. But also, it seems that they feel that patient activation is going to be an important part of this. Now, as I recall, from the Kaiser data, this is Northern California, so you're off the I think that they have best practices and they achieved about 85%. Was that right, based on what we've seen in the past? So the other 15% may be these patient activation things. And I don't know how well they're doing with that, but they have a much more team-based approach. And, you know, pharmacists and other folks running those protocols. So with that, I just want to leave that in your laps and you can digest that with your lunch. And next, I'd like to introduce our next speaker, Ray Bogany, who she says is a wonderful name coming from the shadows of Mount Kilimanjaro.
Yes, Tanzania.
Yeah, Tanzania. So she was born in Pennsylvania, Philadelphia. She's a Terrapin.
I am Marilyn Terrapin, fear of the
So she's a Terrapin. Went to Medical College of Pennsylvania in Philadelphia, and then trained in the combined program in internal medicine and pediatrics at the University Hospitals in Cleveland, Rainbow Babies Hospital, Case Western Reserve. And then I think that you have been in a whole variety of positions since then and have won more awards than anyone I've ever met. So, and she is assuming a new role within Kaiser as far as health disparities. So please help me in welcoming Dr. Ray Boggan.
And Carla is the advanced.
Yes, there it is. Oh, wait, move that to.
So I don't know how many of you all were with us at the summit, but while they work out those technical details, I should say that she's not only an amazing physician and physician leader, she's also an amazing aerobics instructor who even got Arnie Milstein dancing at the summit. It was really quite impressive, and if you join us at the summit on November 5th at Berkeley again, you will have a chance to have a mini aerobics class from our dear Dr. Ray.
And so on that note, good afternoon again, everyone, and thank you so much to the leadership team for inviting me to Sacramento. They didn't realize this was my first time to Sacramento. I've lived in San Diego 11 years. And so I do want to give accolades to our military that's here with us. My husband's active duty in the military, in the Navy, and he is in the medical side as a general surgeon, and then recently trained at UCSF. I saw a pharmacist from UCSF. He trained in endocrine surgery. And so if anyone knows the military and has been married, like I am, or actively participating in the military, it is difficult. And so I let everyone know I'm a very good wife. And supporting our military, however, I'm so proud of my husband's work. And so thank you for what you do in the health, helping the health of our military. And that's one of the reasons, yes, I really appreciate. And then I thank Patty for the introduction and inviting me. And in talking to her yesterday upon arrival, she did say that San Diego was selected as the first city for the Right Care Initiative with the University of Best Practices to make sure that our military personnel were involved. And that's key. I love to attend the meetings. Very similar. We get to overlook the ocean in San Diego when we go to the meetings, and they are on Mondays. And very similar to you, you are, how thick are your windows? An inch or two, very close to the water and outside, but just can't get there. And so that's what I always consider torture. And the speakers tend to be the ones that always give the disclaimer, forgive me if I begin to stare off into space looking out at the water, because it is so peaceful, and so you have a wonderful setting here. And so Patty did give a little bit more background information that wasn't in the biography about me. So if we could actually stand for a moment, you've been sitting for I don't know how many minutes, just to stand up, everybody want to reach for the sky. And at Kaiser, I'm not sure in Northern California, we kind of call these thrive activities. So just during meetings to take a moment to stand up and stretch. Then some of us, as we age, we might want to tilt to the right, and we hold it a little, usually a little longer, but today, for time, just a little bit. Those brave enough can bend down and want to touch the toes. Anybody want to do that? And then take those deep breaths in the nose and out the mouth and just kind of hang. And usually we like to spend more time doing this. Just a moment to stretch. If you wanted to march in place, and that's what Hattie was alluding to, you could, move around the table, the musical chairs, just to remember to stretch. And even when you're at your computers, if you're like us, that's it. Bend the knees. Bend the knees. I see Carla doing that. Just to make sure that you do get up and stretch. And so you're welcome to take your seats. During my presentation, I request interaction and dialogue. I am not here to lecture you. I am the daughter of a retired school teacher, elementary and middle school. And so I know that teachers call on the audience. So it's better to volunteer than to be called upon. Do you remember those days? Let's see some hands. Do you remember those days? Okay, so on that note, team-based turnaround strategies. And so the learning objectives, you have those, just to repeat in the little CME disclosure, I have nothing to disclose. My husband does work for the government, that's not part of it. Wish they paid him more, but they don't. And so the objectives for today, actually, see, this is one of those Kaiser slides that kind of an automatic template. And so San Diego County, we all talk about location, 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 right? Where are you located? So what's that makeup? We want to talk about the leadership. I love sports. Anybody else here like sports? Okay, so those of us that like sports know who's watching what nowadays? Basketball, football, ice hockey,
college football.
Tonight.
College football.
Go Ducks.
Go Ducks.
The Ducks, I gotta tell you, in that bright orange, green and the yellow, kind of like the Maryland Terrapins. How afraid are you of a fighting turtle? Because I think most animals can run away from that terrapin, including a duck, I think. And so once that terrapin gets a hold of you, right, you're stuck. So the Ducks, and then who are they playing? The Bucks. So having lived in Ohio and for a while there with residency and then in childhood, really a Buckeye, what's it going to do? Fall out of a tree? Get hit by a nut? I don't know. So you laugh about my terrapins. However, we got Ducks and Bucks, right? And so owners and general managers, for that analogy with the sports theme. Roles and responsibility. The reason for the transformation. That's the why, the when, the who, the what. Accountability. That's what I call the stats, right? And then the spread and sustainability. And so that's the adopt and adapt to meet your needs. So every organization has a mission and a vision, promise, etc. This is ours. I won't read it to you, just to let you know we have one too. So in San Diego County, who's been to San Diego? Oh, wow, a lot of people have been to San Diego. That's excellent. So you're probably familiar with our geography, and we have geographical challenges. And so I wanted to do a little comparison to Sacramento. So look at the square mileage. Yeah, that's what I said. And then the population. So, well, I'm coming from San Diego to talk to you in Sacramento. San Diego is really big from a geographical standpoint. So today it's about scalability. I asked Carla earlier, I was thinking I was making up words earlier, so if I make up words, just don't tell my mother because she was an English director. So if I'm making them up, don't tell her, but who knows if they still might get added to the Webster's Dictionary like selfies, so you never know. So on that scalability, remember the scalability. So the tale of two counties instead of the tale of two cities, because it's the county picture. So on this, we look at San Diego County. So San Diego County is at the bottom. Does this reflect off? It does reflect off for those looking forward. So San Diego County is here, and right now we're up here. We even got that little, piece there draining off to that river there. So then I exploded, so to speak. I shouldn't probably say that term in a government city, but nonetheless, I show you San Diego County. So why is San Diego County significant? Well, you saw the square mileage. You see the highways, and we're all familiar with the 5. San Diego County essentially is bordered by Camp Pendleton, that's our military, they have their hospital there, and then national forests. We've heard of these being on fire, right? San Diego infamous fires. Then we've got more national forestry, and then we've got what's down here. You got it. And then we've got over here what we like to look out. I do every the Mondays, the ocean. So that geography is very significant, even more significant in San Diego County. Military here, my husband's down here somewhere off of the 8 with the Balboa Hospital. Then you see this 8 highway. Anybody familiar with the 8 highway in San Diego? Great, yes, those that come. And so this is actually very interesting. And so with our leader here, Jose, we do think about the 8. And we think about how San Diego was developed and where it started. So downtown San Diego, you see downtown, and we talk about an area, Old Town San Diego. Anybody ever been to Old Town San Diego? Right, that's where it started. 1850, I think both counties essentially the same time. And so most of the population started here. And then with, I don't know, what do you want to call it, migration, change in the economy, work, etc. Where do you think people went? Do you think they went into the ocean? Do you think they went to Mexico? Where do you think San Diego County residents went? they would go north, right? So, because we couldn't go any farther west. That whole go west thing, we'd all be on houseboats, which might be nice, however, they moved north. So in San Diego County, very significant, and a recommendation that I have, and remember, it's just kind of what we did in San Diego County, within Kaiser, and then with the Right Care Initiative, to know your hotspots. So through the Right Care Initiative in San Diego, I was able to really learn that the Hispanic population and African Americans sit south of the 8. And then the more of the Caucasian population moved north. However, Escondido has a large Hispanic population. So why is that significant? Where my asthma, diabetes, high blood pressure sit. In this area and in this area. Now, who do you think has the heart attacks in San Diego? County level. Here, Caucasians, Qualcomm Central, the geneticists, those that can afford those big homes with the acreage of land and $3.2 million that I won't ever be able to afford. And so that's where our cardiovascular disease is. And my building sits right in here off of the 805, a little bit north of the 8, my clinical building. I do work, clinical work as well as administrative work. And so that's where my building sits. So I have a wonderful, diverse population of patients, because also where I am is a large population of Asian patients. So I may get Hispanic patients because of the 805 corridor for travel. I may get some of those cardiovascular disease patients here in La Jolla. And because I'm an African American physician and not many African Americans live in San Diego, let alone African Americans go into healthcare and become physicians, I then attract African American patients. I also have Native American patients. I call them the, yes, Borrego Spaniards, right? So we have our Native American, right, the casinos. So that's a whole different population. So enough said about California and San Diego County, just to give you the background. So you have this information for Sacramento in your handouts today. I love the handouts. So it's a little small on here, taking it from the internet and putting it on the slide. And so 2007 to 2012 in San Diego County, now if you compare, anybody have their handout readily available? How many medical groups are there on your handout? Can't hear you. I'm gonna, for Bill, I didn't tell him I'm one of those that likes to walk. I don't really stand behind the mic, so he's probably going to get a little seasick. I hope you don't have a seizure disorder, but there is a neurologist here, so you might be okay.
Okay.
So, I can't hear. How many are represented on the data you have for Sacramento?
9.
7, and how many are up here? I didn't even count. 7 or more. So that's challenging. That's competitive. So San Diego County has a very competitive healthcare market. And so then to show you where, I'm sorry, I danced too many. So San Diego, Southern California sits here. Patty, did you want to ask or make a comment?
Well, the wonderful thing about the slide that you pulled off of the Right Care website
Yes, I did.
is that it shows that for our initial University of Best Practices
In 2007, so you see Hattie's pointing there. Green columns.
we had a lot of improvement in the other medical groups, but stunningly, you'll see that Kaiser Permanente Southern California was at 61% of their heart patients at goal for cholesterol control. And that by the time we made this graph for performance year 2012, they were up to 76%, if I can read correctly.
You can.
So the intensive collaborative efforts and mapping and so forth really can matter.
Yes.
But the extraordinary progress that was made at Kaiser represents such a large number of patients.
Yes.
Ray was telling me yesterday after I picked her up at the airport that the number needed to treat, when you translate it into these numbers, the magic 32.
32, and so with our neurologist here, And are there any cardiologists in the room? Endocrinologists? So the data that came across to me, I love numbers. I've shared that with some of you. I love numbers. So that's why I say I'm a little unique, because I'm a physician, my English and spelling has to be correct, and I have to say the right words right from my mother, and then numbers. So I think that's my father's trait. So I love the numbers. And I came across the statistic that we know 1 out of 3 adults will develop high blood pressure, hypertension, and then for every 32 patients that we treat, we can prevent 1 event. So that's cardiovascular or including the heart disease and the stroke. So that 1 out of 32 is significant. Remembering that 1 out of 8 women will develop breast cancer. So thinking about those numbers.
Ray?
Yes?
Quick question. The 1 on 32, and that's the blood pressure and cardiovascular events. What is the citation for that?
I don't know. A lot of this I don't remember.
Oh, okay.
And information comes to me and I remember it. So my citation would be my regional leaders. However, they would have done the information. Yes.
No,
And
because as we move forward, just so the group knows, as part of your guideline discussion, I'll say, we need to have, this kind of information that we can cite, because this is the return on investment.
You got it.
This is the life save. This is the argument. And even to the public needs to understand.
Yes.
It's better than mammograms in terms of,
It is.
you have to screen thousands of women to
Yes.
save 1 life. But
Correct.
this 1 to 32 is a real pointed number. I mean, you just think of us here in the room if we all had blood pressure.
You got it.
And we're treated adequately. One of us would be prevented a
Event.
cardiovascular event.
Excellent.
I mean, it's an important number to get right.
It is.
And just to put it in a similar kind of perspective, if you look at people who are getting surgery for carcinosis, asymptomatic carcinosis, which is pretty common surgery, you have to operate on around 85 people to prevent 1 stroke.
Gotcha.
Can you say that a little bit louder? And can you please get the microphone?
You have to operate on over 80 people with asymptomatic.
Speaking of health.
But that way they can all be.
The NNT number needed to treat to prevent 1 stroke if you're operating for asymptomatic carcinosis is over 80. So this seems to be a much more worthwhile investment.
Excellent.
So we would love it, Jessica, if the Department of Public Health economist could help us take that number and translate into lives saved.
You got it. That's it. And the cost saved from that. So you got it.
There is a resource that you might want to be aware of. It's called Number to Treat. It's a website. You go to the website and it'll give you information on number to treat for a wide variety of any.
So that would be the source.
Does everybody know how to get to the number needed to treat? So it's an absolute risk reduction. So if you go from 10% of people would have that to 7%, your absolute risk reduction is 3%. Divide 1 by 0.03, 33. That's the number needed to treat. That's how to do the calculation.
Right.
So it's based on the absolute risk reduction.
Is there another question, comment? And so tagging on to what you said, John, for bringing into other diseases, colorectal cancer, and like you were saying, Jessica, if I may, I like first name basis, so please call me Ray. And so with mammography you mentioned, then there's also colorectal cancer. It's like 400 of those exams to find the 1 cancer. So this is significant. So I appreciate that you appreciate how important this is to the lives of your county, our capital area. So as we move forward, our leadership structure in San Diego. So I'm not sure if everyone is aware of structure within Kaiser. Everyone tends to know that Kaiser is big. So again, remember, what's our word of the day? Scalability. There you go. So you may not have all of these, as sometimes we call them cooks in the kitchen. And so just determine who's your, now I like food, so to me it doesn't matter who cooks the food, whether it's the sous chef or the line chef or the baker making dessert. So if you want to look at it with the food analogy or back to the sports analogy, we have National Kaiser sits out of Burbank. California Kaiser sits in Oakland. Then we go to 5 regions: Hawaii, Northern Cal, Georgia, Mid-Atlantic, and Southern Cal. Our capital of the United States, Washington, D.C., Maryland, Virginia, Georgia, and it's really Atlanta area, Northern Cal, Hawaii. In Southern California, so again, you know more about the geography of California, probably than I do. However, the map that we refer to, within Southern California Kaiser, there are 13 regions. So, excuse me, the region, so it's the 5 regions in the national, the term is actually service area. So there are 13 service areas in Southern California Kaiser Permanente. With San Diego County, we say San Diego, however, it's the whole county. So all that square footage that we discussed, that's the significance. In San Diego County, there are now 14 medical buildings. Yes, this PowerPoint is small because this is the extent that my PowerPoint 101 class got me to. With putting this together so that you can see it. And so my little building of Claremont is right in here, and one of our newest is Carmel Valley. And so these are our buildings. So they cover that south of the 8 and the high cardiovascular disease area where I am, Escondido, where the Latino population. So again, we understand those 13, now 14, because Carmel Valley is about 2 years almost. These are 14 buildings within San Diego County Kaiser that have primary care physicians. There are actually 22 buildings or more and a hospital. All of the data for all of the cardiovascular disease measures is tagged to a primary care physician. Is yours set up the same way? Yes, no's. How many have medical groups where the data is tagged to a primary care physician? Can't see the hands. 2, 3. So who is then responsible? The whole medical group, the building, can you share with me? You're going to teach me something.
It depends. It could be by the individual provider, depending. It could be by the site, it could be by the specialty, it could be by the group.
Okay, so multitude. The way we do it within Kaiser for standardization, if you will, is primary care. Because not everyone goes to nephrology, cardiology, etc. However, you understand that magnitude. So sponsors.
How many members do you have in
Great question. We have 537,000 members within Kaiser Permanente, San Diego County. So larger than the population of some of the counties, not larger than Sacramento, 537,000 members now, and growing with the Affordable Care Act. So that is also significant. And that's why Hattie was giving me such accolades. I love doing what I do. So each of you probably have sponsors, right? The team owners, right? Your general managers. So that's what we determined in San Diego. Medical directors or administrators, inpatient and outpatient quality leaders, expert condition champions. What's that mean? We're able to have someone lead hypertension, asthma, etc. within San Diego County. The cholesterol leaders. So diabetes comes and is being led by an endocrinologist. Hypertension is a primary care physician. To have those 3 measures led by the experts so they can field all of the questions. As Hattie said, Yvonne and myself led this department. I was the physician director of complete care management in San Diego for 4.5 years. There is absolutely no way I could have done this by myself, and there's no way Yvonne as a pharmacist could have done this. And there's no way we could have done it together. So you have to have your sponsors. You would be the quality leaders, your expert condition champions, and then supporting departments. More on that is our San Diego example. So I said, a lot of cooks in the kitchen, you got a lot of players, right? So again, national, regional, local for Kaiser, we are unique with the medical group, the health plan, the hospital, the medical directors and CAOs. So we have that in San Diego, the assistant medical director and administrators. This is where complete care comes in, and that's where I heard from Kristen. So I was her equivalent in San Diego County for 4.5 years. So that's the outpatient. So they become the center with the patient. They know the most about all of these measures, and then educate up and down with the expert conditions collaborators. Key. Specialty had to get involved. There is absolutely no way primary care could do this, and I'm going to tell you why in a moment. And then ancillary staff, radiology. If we're going to increase and push to screen for more breast cancer, radiology probably needs to know. Lab, if we're going to draw more potassiums, creatinines, etc., lab probably needs to know. If we're going to collect more A1Cs, if we're going to do more diabetic eye exams, they need to know. So the communication structure, yes, our Office of the Patient Advocacy is here, and the patient is at the center, always. It's always to do the right thing for the patient. However, then what do we have? Senior leaders, all the providers, the experts, ancillary, and complete care. So do you have a quality department? Do you have that within your health plans? Yes? Hands, yes? Okay. And do you put them at the center? Yeah, of course, as a female, you know, growing up with 3 brothers, no sisters, the world centered around me. I was sharing that with Carla this morning, right? An adolescent female's the center of the world. That's just what we think. That's our culture in the United States. It's not good or bad, it's just what we think. So with complete care, we were the experts. My job was to know more than my medical director. That was my job, to support them in any way I needed to, and to then seek the assistance of all the providers. Very key. So with that, Michael Cantor is the regional, which means Southern California, when you think of the structure, quality leader. So he is the Executive Assistant Medical Director of Quality for Southern California, overseeing the quality of all of those 13 areas. 3.2 million patients. So of the 3.2, which now is probably 3.4 million in Southern California, Kaiser San Diego has 537,000 of them. So as Hattie was saying, and then to reference with our military here, we're a pretty big ship. We are not a boat. We are a big aircraft carrier, right? 6 flights, aircrafts, all that, all the people. My husband described it as a city in a city. I mean, they did everything from woodworking to making clothes to everything on the aircraft carrier when he was deployed. I couldn't believe it, because they have to survive out in the middle, literally in the middle of the ocean, to keep us here safe. And so with that, we're huge when it comes to San Diego. So just scale down and just think about, man, I'm glad we're not San Diego County, because that would be a lot. That's all you gotta do, just think about that. Just think about, I am so glad I'm not Raggedy Vaughn if you don't have the 537,000 members, right? Because remember, when you hear someone else's heartache, it's like, oh, guess my life's not so bad, right? Any of us do that? Come on, I know when you see patients, right? Yes, let's see the hands.
Glad we're not in Paris.
What's that? Exactly. But life could be worse, right? So the chronic care model. This goes to that complete care. The article reference is at the bottom. So then with hypertension, one example, because we have hypertension, diabetes, cholesterol, and we only have a little bit of time today. And I know we can be overwhelming. That's why I ask for interaction. I know this information can be overwhelming. So I want everyone to walk away with some strategies, right? So our playbook. So this came to us. These are Southern California Kaiser patients divided by race and ethnicity. Now I know we have a computer system, and about 4 or 5 years ago, there was a lot of angst in the departments. Why do we have to find out what the ethnicity is of patients? Well, I stopped asking the why, because anytime the back office staff is asked to collect data, or the service reps or whomever, talking to the patients upon becoming Kaiser members, when they ask those questions, I know it's going to help us down the road. So 4 or 5 years ago, probably 6, we started to ask, and go figure, look at this. With that data, we're able to find which population do you think this is if you can't read the bottom? You can? African American. Has anybody else seen a disparity? Does anybody else have disparity data? Okay. So there you go. So with this, yes, Northern California Kaiser season.
It's the same.
Yes. So this is Q3 2012. So what's that put us at? End of the year, July, August, September, something like that. big gap. I mean, that's significant. And then look who's at the top. Who's our little triangle up there? Now you think, well, wait a minute. How can they have controlled blood pressure with soy sauce and the mustards that come when I go get Asian food, right? How come theirs is better? So you start to ask why. So we dig a little deeper. And each of those 13 areas in Southern California receive these scorecards. And there's regional data and there's the area data. Part of that unblinded data that our leaders talked about, right? Now, I talked about sports, right? And I'm kind of competitive, right? So, as Hattie was saying, kind of worst to first, well, when you present some data in an unblinded manner, and I'm in a position on the team of quality in San Diego County, and we're told that our gap is one of the worst at 6.4%. What do you think I did? With my team, it's not just me, with Yvonne and the whole team. Do you think I said, whatever? Yes? No? No way! So that aircraft carrier, that nuclear power had to get going. Well, that was, as Hattie alluded to, huge. However, I love doing it because we do know that Kaiser has data and an analyst, and we have information and all of that. So with what they could do and take and bring to us, I didn't do it on my own. Yvonne didn't do it on her own. We just knew we needed to do something. So what's the something to get us from worst to first? Well, we said, well, is it true in San Diego County? And look at this. Who's got more coronary artery disease? 2009 data presented 2012. Can't hear you. Who's in the back row? I see Liz back there. Who's got the higher coronary heart disease? Which race? African Americans. Well, what about stroke? Can't hear you.
African Americans.
So in the county, it wasn't just San Diego. So then we said, well, what kind of issues could there be within Kaiser? What about identifying the high blood pressure? And then controlling it. So are we identifying it? Do African Americans tend to come into the doctor? Yes, no, maybe so. Do they? No. We know there's a lot of history on that. A lot of history on that. And then look at these other numbers. Specialty. Anybody pick up on that word? Yes. Look at this. We heard a little bit about mammograms. So with this, 40% of patients are seen in primary care, which means the bottom line, how many are seen in specialty?
Well.
So why would primary care have to do all of the work if they don't even see 60% of the patients? Hence, the business case for specialty. That's what Yvonne and I also did. So,
Great.
yes.
Great. Do you think that's more particular in Kaiser than it is in others? Because most of we task our primary care physicians with doing this. Yes, there are some patients that only see specialists. But, so, just a question.
And actually, I believe, was it the summit? Hattie, Liz, Carla, where we had heard at the summit about patients being seen in specialty departments. Whether it's the dermatologist, OB-GYN, orthopedic surgery, eyes, right? Psychiatry, mental health, those are the big five. So if you like the Fab Five basketball, if you like the Big Five, High Thrive, those are the big departments where patients prefer to go. Doc, I want to go get my eyes checked. Send me to optometry. Send me to ophthalmology. I want to get laser surgery. I want to get what have you.
So
I know.
So this means 40% of the visits. It doesn't mean they don't have a primary care.
That's correct. They're all assigned. That's the goal, to get them assigned. However, do they come in?
That makes sense.
And I've had patients, because of the work that I do, come in and they'll turn in the FIT test, what do you call it, for colon cancer screening. It's a positive test, go to GI, get a colonoscopy, and still not have a primary care doctor. I've also had patients come in and they will, not my patients clearly, but they will, in San Diego County, they're all mine. They come in, they get a mammogram. I was the ordering physician, so the radiology techs would put my name down as the ordering physician. Do unto others as you'd have them do unto you. If anybody comes in and wants a mammogram and it's time for it, I was the ordering physician. They may not have a PCP, they may have a PCP. Then I would order the test and they are off to get their cancer treated and still won't get a primary care doctor. So our goal then is to capture them and get them assigned. Specialists have to be involved. And it's a matter of having difficult conversations. And that's what I started to say with, I'm an internal medicine doc. Primary care doc. I didn't train in cardiology. I didn't train in pulmonary critical care medicine. I do not want to take and replace anybody's knee, shoulder, anything in surgery, vascular surgery, CEA, no. No, 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 especially podiatry, no. So they went through some different training than me. So in the medical profession, where do you think in that hierarchy I was placed?
Closer.
There you go, you said it, Dr. Earl. Thank you, thank you, thank you for... Is there a therapist in the building, please? So I've been able to accept that, and that's what I do. I walk in, and it's knowing the audience. For today, I knew you were high-performing, high-functioning. You're not when I talk in the community. Different population here in my audience, right? Well, I'm married to a surgeon, right? I know how to talk to surgeons. The first thing you got to do is blow up their head. It already can't fit in the door. The doors are open here, but you got to make it bigger. And you got to tell them, thank you so much for your time. I know how busy you are. I'm not going to take much of your time. This is what I need you to help us with, and why. The why, the data, the hit them. Get credit for what you're doing. We need your help. And then they're like, wow. And clearly I have a way with words. So I motivate you. Get 80% of the people to do it. You can make change, right? So that's what it's about. So as I move forward, the improvement process, data, education, providers, right? Treatment algorithm. Who talked about an algorithm today? Process change. Hattie wasn't aware of the patients with blood pressure. If they're over 70, they could stand up. Keep that arm at heart level. Also the patients that are on high-dose diuretics. Who might be in the category of a high-dose diuretic where they go 3 times a week and get hooked up to a machine? Dialysis. So all nephrologists in Southern California in those departments, they take the blood pressure standing from the get-go. So just knowing that. Yes, Mary?
So right, in terms of the specialty, the specialists, what exactly did you ask them to do?
Right here. See, Mary, you are right there with me. I appreciate you, Mary. I appreciate you. So what do we see here? Excuse me. Specialty. Educate them on the importance of their role. And just give out the recipe and the tools. Now, we all know neurosurgeons and orthopedic surgeons, in order to get into those residencies, they were the top 2, like 1 and 2. Correct me if I'm wrong, John. Correct me if I'm wrong, Kristen. Any other physicians. They were like the top 2 in their medical class, right? In order to get into orthopedic surgery and neurosurgeon, that's what I remember. Brilliant people. However, when they get into their surgical specialties, they act like they forget blood pressure, diabetes, right? They just like forget because all they want to do is operate. And I mean, no offense, that's my husband, right? I mean, no offense against him, but his favorite patient's the intubated patient. We all know that. Where I want to develop a relationship. So when it comes to this, it's educating them on the importance of the role. Again, that head, right? Patients listen to the specialist. If an orthopedic surgeon gives out a handout. So what kind of handout, Mary? If you don't mind, may I ask you or Carla, it's the Eat Less Sodium handout. This is all we would ask them to do with any patient with the diagnosis of high blood pressure. I may not have 50 copies because I traveled light, carry on from San Diego. However, I can get you these. So that's all we would do. Standardization. Academic detailing. Taken from Woodland Hills. Why would San Diego County want to reinvent the wheel? I don't want you to reinvent the wheel. Adopt and adapt, I said earlier. So education at the smaller level. Unblinded data. unblinded data. We can break our data down to the departments. Equitable care and health outcome strategies. So yes, at Kaiser, out of our national offices, we have a department called ECHO. We talked about African American patients not coming into the doctor, right? So we need to do something different. We either take the doctor to them, right? Mobile health vehicles, community locations, little booths, something, right? That's why medical groups are going into Target and Walmart, right? Next, we need to go to the, what do you call it, automotive shops, because people get their car repaired. They'll go to the dentist before they come see us. So nonetheless, this. And so now Mary, I'm going to get Mary exercise. Sure. This is one of our handouts on the equitable care with these tools. Again, I may not have enough. However, I can get you more to Hattie. So as we move forward, the algorithm. You do not have to adopt our algorithm. Our leaders talked earlier. Standardize, standardize, because at Kaiser, when we shared, start with the diuretic and the combo, and then go up, and then if they were ACE intolerant, use one of these. Then we talked about calcium channel blocker, beta blocker, spironolactone, and so remember we now use, we use at Kaiser amlodipine. Medications are generic. The costs stay low for the patient. I was watching the news, I don't remember, it was a money talk on one of the news stations last night, and they said the best things to purchase in generic are actually juice and medications was one. I said, oh, I love it, because a lot of patients want brand. So the algorithm. Then non-provider strategies. Call in patients who are overdue before they're overdue. Remember with the lovely HEDIS data, if a patient doesn't have a blood pressure within the past 12 months, they're actually uncontrolled. So sometimes just getting them in, reminding the patient. And I shouldn't use this term in a government city, however, I hold medications hostage. So I will fill in and put on my prescription, what is it, Prinzide, 10, 12 and a half, one, POQ morning, and then it says, dash, needs primary care appointment and labs before next refill. I'll give them, we give 3 months supply, 0 refills. They try it again, I go to 30. They try it again, I go to 14. Sometimes then, they're like, why am I paying the same amount? And then my nurse now can handle it, because they could say, well, Mrs. Bogany, your medication says right there. And we've done outreach, right? And complete care management, which I highlighted in red because I was part of that department, and it's integral. Letters. We took this from West LA, letters to African American patients with the PCP picture. Also one way to introduce yourselves to new patients, right? So something we did one time, we haven't repeated it in 2-3 years, but it was one strategy. So you probably want to know what happened in San Diego County. And so where were we? What was the number of the disparity? 6.4. And then in here now?
3.6.
And we hit 3.1, and the goal, 3.2%. And some people say, why should we even have 3.2% of African American patients not at the same control level? I like those people. I can't answer that question. It's not acceptable. We don't want any disparity. However, we've got to work to close it. Now you also notice the trends, and this is what I was sharing with Hattie, where 3.1%, 3.6 to 3.7, and you notice then what happens also to the white patient control. End of the year, right? So end of the year trends. Anybody else see those trends where blood pressure control goes down towards the end of the year? All right. We talk about, this is the belief of equal, however, we're moving towards equitable. Any environmental justice, public policy? Yes, I know. Yay, yay. So, some of you may know, my daughter is, so I have 3 children. I mentioned my husband, and I have 3 children. My daughter is my oldest. I had her early in life. So she's actually a grad student at UC Berkeley. She did chemical engineering at UCLA and is now doing environmental engineering at Berkeley. So when I went to the summit, she was my, I called her, she provided my hospitality suite. And when I arrived, you know, in her apartment there in Berkeley, she had the towels folded on the bed for me. There was no mint on the pillow, and it was great. I stayed up there with her. It was her birthday, so I got to celebrate her birthday with her. She turned 24 in October. And so with environmental engineering, she's familiar with the, where's my Berkeley, the Haas School of Public Health. And so because even though she's on the engineering side, she wants to do more public policy work and public health work. She doesn't want to build like environmentally green buildings. So it's kind of unique that here I am doing my medical stuff over here trying to improve the health, and now I got what she'll always be my big girl even though she's like 5 feet tall, that she's doing improving the health through her environmental engineering track. So I'm very curious to see where she's going to go, and we've actually attended some conferences together, and the buzzwords, so I'm learning the buzzwords, Liz, from my daughter. So very important about equitable. Equitable. Yes, you want to say something, Liz? I can tell. I can tell. I'll read it.
You know me too much.
I do.
Okay. I'm Liz Holtz, California Chronic Care Association. So, okay, let's talk about patients that are in the alcohol. Okay?
Yes.
Let's talk about the team. Let's talk about psychiatry, where so many people go because stigma. They're not going to go to a regular doctor, but they are going to go see their psychiatrist.
You got it.
Feedback I get all the time, my doctor does not take my blood pressure, or he doesn't take accurate blood pressure, and I don't know what it is, and how do I do that?
In the Department of Mental Health?
Yes.
Or in any department? Mental health?
Mental health is my focus at the moment.
Okay, mental health is a challenge. So, most of for Kaiser, most mental health departments don't have blood pressure cuffs. So you bring up a very good question. And we are in a political city. Most of you have heard about the Kaiser strike, right, with mental health. Being married to a military physician and seeing that I am, though not trained as a psychiatrist or psychologist or social worker, my 20-minute appointments, I am a well-paid nutritionist, as I shared with Hattie last night, and a well-paid social worker, marriage and family therapist, psychologist, because I'm not a psychiatrist. That's what I have to do because patients want to come see me because of the stigma. So we're trying to figure out how best to meet the needs of patients with mental health. What we realize is that the mental health department is, just overwhelmed. I'm sure, right? Everybody's likely is. And so with that, we asked them, what could they address, Liz? And so rather than checking the blood pressure in that department, this is where they need to come see the primary care doctor. And then on that note, what could the mental health department take care of? What about tobacco? What about tobacco? So we've worked hard to ask them to address tobacco use. For me, correct me if I'm wrong, things may have changed. When I did my addiction medicine way back, that rotation, patients that go to mental health, we do think about drugs, right, alcohol. So if anybody's been to an NA meeting, an AA meeting, any of those, they typically smoke and drink a lot of coffee. So cutting back on the coffee helps, maybe making it decaf, but to address the tobacco use. In San Diego County, we have a lower tobacco use. Most of the tobacco in San Diego County is by the LGBT population and the military. And Kaiser has no smoking. So we kind of go to behavioral health and ask them what they would be able to do, though I'd love them to take blood pressures. So could we put a blood pressure machine or an MA that just checks them in? That's staffing, right? So to put them in the hallway of the building and they check everybody when they come in. Something, and what we've learned at Kaiser, we also have the data where not everybody needs a blood pressure every appointment. It's once a year, right? So we then have cues on the computer where if it's not needed and your specialty, don't check it. Now we do know the surgeons need it for pre-op, etc., or even GI for a colonoscopy procedure. And so otherwise, don't check it because it's the way it is. I need no harm, no foul. They have specialty departments may not have had the proper training that the patient's sitting, no talking, feet flat on the floor, etc. We're in primary care. And so we we kind of fight those battles as we can.
So Dr. Robinson wanted to ask a
Yes.
question.
I had a question. If you are able to offer opportunities to get blood pressures checked outside of an office visit with a physician.
We do offer those.
Okay.
So at Kaiser, because it is the HMO setting, we will have nurses clinic in the buildings with primary care, and we will now, instead of the patients going to the nurses clinic to check a blood pressure, we actually ask the patients to schedule a blood pressure check in my office. So then we have an MA that has a full schedule, and we actually schedule the patients to come in for a blood pressure check. If I'm in the office, I will then adjust the blood pressure medication if it's the second or third check. If it's the first one, right, we come back, we want those 3 blood pressures on different occasions to actually diagnose it. And so we do those checks and we can adjust the medicine. With the holidays, some of my colleagues were out of the office, so then I adjusted their patients and vice versa. Great question. Oh, okay. That's time. I hear it going off. That's Warren's time.
Well, let's just take some time for Q&A for you. I think you've raised a lot of very important issues. I've never heard said in any right care meeting, and my goodness, I've had hundreds of them now, that in order to properly diagnose it, you need 3 different visits. Could you elaborate, please?
Correct me if I'm wrong. If the diagnosis has changed, we usually like, what's that, Kristen?
Oh. I would say 2 to 3, yeah.
So it's 2 to 3, because if the patient comes in and it's the 180 over 110, well, right. So depending on how high. If it's the 140 to 150, we say let's come back. And then some people, we used to say come back in 3 months. No, I like to bring them back. What about the other physicians? When do you like to bring your patients back? Yes.
2 weeks.
2 weeks. And I have had a patient, a 50 to 60-year-old white male that saw me, I think he saw me maybe 2012, and he hadn't seen me since 2010. His blood pressure was high. He was supposed to increase medicine and come back in, and he never did. So when I saw him again in 2012, it was after he'd had a stroke. And so blood pressure of 142. All it was in 2010 was 142 over, I don't know, 80, 70, and he had a stroke.
So when you have a patient who has a 180 over 110, that moment, what do you do? What's that day look like for that patient?
So, anybody else want to answer that question? Again, I don't have to do all the talking. Pharmacists, you probably know, huh? Do you know? Do you do any of the treatments?
Well, we had that, obviously, if that's a new patient, it would go directly to a physician for advice, we wouldn't be diagnosed.
That day. That day. If it's a new, so that is part of the, what is that? Oh, we call it protocol.
Scope of practice.
Scope of practice. So the diagnosis comes from a provider. And that could be, though, nurse practitioner, physician assistant, or medical doctor, MD, DO. It doesn't always have to be just the MD.
And how soon do you have them see the MD? And after you're done answering that question, Dr. Hartman, would you answer that question?
So I would say I would consult with the physician right then and there, either via telephone or in person if I had the capability. I wouldn't let the person leave right now.
That's right. And others, go ahead.
Yeah,
She volunteered you on that one.
It depends on how severe, but yeah, at a certain point, I think the person needs to be evaluated. If it's severe enough in the ED, but at least a telephone call to the person's primary care doctor and a recommendation regarding blood pressure medication at that time, especially if this was an initial diagnosis.
How do you use these guidelines? And how do you promulgate them, and then do you provide feedback to doctors about pieces of this or the whole thing?
Yes. So, did you hear his question? So, when talking about the algorithm, whoop, there we go.
So this is a several-page algorithm, which I will get from Ray, and I'll post it on our Right Care website for all of you to download if you're interested.
So within Kaiser, out of the national offices, and I apologize, I did only bring, I think, 4 copies. I did not realize that when I made the copies, they weren't double-sided, so I thought I actually had more. So nonetheless, exactly what they talked about earlier, it talks about, this was August 2014 out of Kaiser, and it's out of our Care Management Institute, which is the national office. And so with these guidelines, it actually goes through the why, the what to do, and the medications, answering the questions that Dr. Ertl asked his physicians. And so coming back to this slide about primary care provider academic detailing, so review key hypertension messages. It might be to show them where this is online, right? We're trying to go green, show them where this is online. And then with the unblinded data, for them to actually come and say, well, Ray, you know, in San Diego and Claremont, out of the 33 doctors here, you're in the lower third, or you're here. And to say, are you aware of the guidelines? And some doctors may say yes, no, maybe so. Are you aware of the SALT handout, how significant sodium is? Are you aware of similar questions? So to spend that time, so again, large organization, a lot of square footage to cover, so how to get all of those leaders involved and the stakeholders in buy-in to understand the why, and then to have those right people having those conversations. And so you probably have seen some of the data, or talked about it here, how lowering the salt helps, how exercise helps lower the blood pressure, being more active, no tobacco, cutting back, all of those questions. And so it's a stepwise process. And to answer the question then also, if we get 80% of the doctors to start Prinzyme and titrate up, and then go with the next medicine, calcium channel blocker, and then go with spironolactone or the beta blocker, depending on their disease, because if they have coronary artery disease, a beta blocker we might put in sooner, right? Rather than the calcium channel blocker. And so we do specify this works for majority of the patients. And in San Diego County, we have a lot, last numbers I saw was like 112, 117,000 patients with hypertension.
So, do you incorporate that into your clinical decision support? I know you have DHL.
Yes. So, let's see. If I clicked in, yes, so in the computer system, think about sitting at my computer with doing patient care, we do have that. Correct me if I'm wrong, we're going into the computer, we can go in on our system to the recommendations for patients to see what would be the next step. So our computer system, knowing the patient is male and this age or female and this age, and then making the recommendation for cholesterol medicine or blood pressure medicine, and you know when to come back. So we do have some of those cues.
So in San Diego, do you start with a combination drug, or do you start with single?
Straight to combination, unless there is the history where they had an allergy to the ACE or something like that. Otherwise, we start right away, and we started this. This is memory in chronologic order. I've been in I was in the role of complete care management for about 4.5 years, and I think we made the switch maybe 2 years ago to Prinzyme. How long ago do you think it was with Kaiser? You think so? I think it was about 2 years ago we made that change, and then anyone who was not on that combo, especially with the diuretic being the first line, then we would actually in the system pull out patients who weren't on a diuretic, find out why, and get them started on the diuretic, and then make that conversion. If they were on, you know, an ACE, say, well, you aren't on a diuretic, explain to them why I didn't know I was supposed to continue that medicine for life, and then say it's a combo pill and the same cost for generic, so that it's not going to have an increase in cost.
So I don't want to bypass this. I think this is a critical and key piece of this, and thank you for that information. But what sounds like is very powerful is that you actually provide individual data by practitioner on their patients that actually tells them how they're doing. So that actually is very, very powerful to get data that says this is how you're actually doing. These are your patients, and this is your mean percentage of patients who are controlled, so that they can then be able to say, yeah. And you provide that in a so-called private public forum. So in other words, all the doctors are able to see, where do I stand next to my colleagues? And that's a driver for improvement.
Thank you for saying that.
I don't want to bypass because that's
That's absolutely key because, again, most of us went into our profession and we're very competitive to get to where we are, right? We were the, answer the questions in class. Ooh, pick me. I even tease some of my colleagues. I bet you used to volunteer to clean those chalkboard erasers. And they laugh or sharpen all the pencils because that's where we wanted to do more and do extra. So why should a patient come see me and I address the blood pressure and get, 65% of my patients controlled if other colleagues are working harder to do better? Yes?
Do you have a guideline? This comes up all the time with the work I do with patients in a medical home. How many visits with the physician versus other members of the care team? It's like the doc says, but if I don't see them every 3 months, I'm liable.
So great question. So to tackle that question, we do have data where the patients come in either to see the provider, the physician in primary care, or other physicians in specialty, because our data can be driven down to specialty as well. When it comes to, did the specialty back office staff check the blood pressure when they were prompted or not check it? And then the opposite, did they check it when they weren't prompted? And if it was high, did they check a second one? So we do have an advantage with the data available. And so we can drill it down to that level. So then when it comes to the other data and when they're coming in, we can drill it down to the physician in primary care or an ancillary staff, not to did they come in to see just the RN or M, and I shouldn't say just, but to come in to see the back office support.
And then who reviews that to be sure they're getting seen?
And so that's where the data is always coming down to the physician, and when that data is presented from the building manager or how we have it set up, then that would be for the building managers in primary care to disseminate it to the providers at the provider meeting, and then to the leaders of each module where the doctors are on a team, that medical-based home of about 6 doctors on average. Anything else to add?
Juanita had a question.
Does that answer your questions? I'm hoping I... Okay. Because the primary care doctor is always the responsible one. If the patient went in to see cardiology, nephrology, endocrinology, orthopedic surgery, derm, optometry, we are still the ones responsible. So when we get the list and the patient hasn't been seen in the 9 months, then we need to get them in. So it's still down to primary care.
You're managing it because you have the data on where they're being sent.
Right. And then we know who to go talk to. So if the back office staff in one of the departments is checking it when they shouldn't be, or checking it incorrectly, or the patients always have a high blood pressure, then that's the back office, what do you call the staffing education departments, to then educate on how to properly check the blood pressure.
And then you quickly listed the 5 specialty locations.
Oh.
What are those 5?
So the 5 most highly utilized departments within San Diego County outside of primary care are mental health, psychiatry, then optometry or ophthalmology, I call those the eye guys, orthopedic surgery, dermatology, and who did I miss? OB/GYN. Well, I kind of put optometry and ophthalmology together. The eye guys, I call them, kind of come together.
Juanita had a question.
Yes, you obviously have had so much success in order to have received that award.
Thank you.
And in doing that, you must have then incorporated, or how did you integrate in their like cultural differences, you know?
Did you
like
get
food.
Did you get one of those, some of those handouts? Did she get the Echo one that's green? Yes, so anybody want to share with her that one? So, when it comes to the cultures, I do love food. And so, I won't say I perseverate on food, then I'd have to go to Food Addicts Anonymous. However, knowing their different cultures, and I do not want to say cut back on the way I grew up. Wonder bread, cornbread, sweet potatoes, white potatoes, that kind of thing, to someone who I know may eat tortilla, Spanish rice, Mexican rice, different types, naan, right? Different types of carbohydrates, potatoes in the food, the yogurt in the sauces, right? So understanding those cultural differences. I mentioned my Asian population. Well, how much soy sauce are we adding to the food, right? How much processed food? And so that's where I take it upon myself, and when I go to meet with others in San Diego County, it's expressing that. And we actually did a CME, a full hour at one of the primary care meetings on this topic. So I know I didn't have enough, but we actually did this with that AIDED topic. And look, this one I've had in my bag so long it's kind of melted together. And so I think did that come, that's these. And so we actually did an hour. And we actually did the audience response system, and we talked about these 4 habits and investing in the beginning. I must, meaning you must, walk into certain cultures. I recommend it for anybody that you're seeing, any patient, and say, hello, Mr. Ertl. I'm Dr. Bogany. Nice to meet you today. Usually thank you for your patience, because I'm usually running behind. And the patients always respond, how can I be a patient without patience? And so that's the little humor. I have to invest in the beginning. And then as I'm logging on the computer, what have you done since I last saw you? How was the wedding? How was the this? How's the cat? How's the dog? Did your child go to Berkeley? How'd they do at UCLA? Right? As I'm logging onto the computer, talking to them, the 4 habits, demonstrating empathy. Wow, that must be hard if you have, kids and trying to afford this and do that. Your husband's in the military, this, that, or the other. Mine's in the military too. The kids and sports. Aid it, acknowledge them, introduce, duration. Cannot seem rushed. And with African American patients and others, touch of a stethoscope, the doctor didn't touch me. Have to touch on the shoulder. Legal touch, on the shoulders, right? Compliant touch. And say you understand. Don't stand up in the office. I always sit down. Explain. You need to take this medication. It's a combination medication. It's what we use first line. The evidence shows that this is the best medication because the salt in the diet, it helps the kidneys. That's Prinzide. And knowing the history. Not to say try with any African American patient, because what's the trial? Tuskegee. Oh, I'm not being a test rat. I'm not a gerbil. Do not use the word try, and thank them for their time. I thank everybody. Why would I do something just for one group? Thank them. And then being knowledgeable of the types of food they eat. I say in my culture, it was Wonder Bread on the table. Oh yes, I remember that. Talking to them about the sodium, they come back. I ask them to read food labels. Did you know bread has sodium, Doc? Yes, I did. And so showing them. Sodium is salt, layman's terms. Don't talk above. We've all been taught this. Don't talk above them. Salt is sodium. You tell them sugar. Found this out. My patient was so proud she brought in her oatmeal from Costco. Said, Doc, I even brought it in. She's taken it out of her purse. I said, oh, good, right? You congratulate them because she brought it in after the next visit. Let's see. So see, it only has so many carbs. I don't know what she said, 7 grams of carbs or something. So I said, you're right. It does have total sugar of 7. I need you to go up 2 levels. The total carbohydrates is this one, and it's 24 grams or 45. I didn't know it was that number. Hence, I'm a well-paid nutritionist. We do not have enough nutritionists and behavioral mental health providers.
Now, I would understand if all of the Kaiser patients were your patients, why you would have reached the national 90th percentile. Obviously, that wonderful energy. But how did you get the rest of the physician and clinician community in San Diego Kaiser to close that gap? What did you teach them?
Everything that I just said today, maybe some more details, but everything that I went over. Who's responsible for the patient? Who does the algorithm? Who checks the blood pressures? Who does the education? It's a team. We have health education, right? We have primary care, we have specialists, we have the staff educations, we have CME for the primary care docs. I then would selfie invite to cluster meetings for the specialist. So that, again, the structure, If leadership knows the value and the significance up here, it's a top-down, right? So it's a mandate that we need to make improvement. So as we come down and get one step at a time, right, buy-in, put complete care in here, and then continue to get buy-in, we manage to get more and more people aboard our aircraft carrier. And seeing the why, saving the lives, 1 out of 32. Give credit for what you're doing. Increase the medication, making it easy with the algorithm. I was wondering why my patient wouldn't change their medicine. I use the word try. How many docs in San Diego? We have 254 primary care doctors, last I heard. How many said, I use the word try? I didn't know I was never supposed to do that. I didn't think we could touch a patient. I don't shake my patient's hands, right? We all talk about germs and all of that stuff. Well, my hands you don't want to touch because they are so dry. I think I have more than 3 layers of skin because every patient is 2 hand gels and 2 washes, right? So that they see it and I make sure I stay healthy. And so it's really explaining this, and out of this, someone will pick up, what did I say at the beginning? One thing. And if a doctor can pick up one thing, Prinzite, I didn't know it was that easy, just Prinzite. We start with a half a tablet of 21 and then go to 2, that's it. Get them back, you mean we could do an in-module blood pressure check, that's it. We could send them to a nurse clinic, that's it. We have health education to talk about sodium. I didn't know we had this handout. One thing, and that's what makes the difference. So acknowledge the different cultures, right? And so those are the enhancements and the importance of family. So did that answer your question?
I have one little follow-on, I'm sure you're surprised, but could you talk about the variation in treatment for different ethnicities, scientifically, what changes in the algorithm?
Let's see, where was my algorithm? Perfect. So with the algorithm, we heard Dr. Ertl, right, say which is the first line medications. The majority of the room said diuretics. Why is that? Cheaper. She says cheaper. What else? Effective. Why? Evidence. What evidence? What's that? A control trial. Why? Diuretics get rid of water, which brings sodium. There you go. Sodium. Has anybody honestly read a food label lately? Or does anybody have anything in here like a breakfast bar, a Gatorade, and anything? Any food item? Okay, what's on that? Thank you, Liz. Uh-oh.
Okay.
I won't say who gave this to us. We have a microphone for...
No, let's see. These are cashews.
Okay, so she's got, read the full label for me. This is what I do with my patients. Or in a class, right? Health education. So, Chad, go ahead.
So what, you asked me to read all the nutrients?
So the name is, she said cashews, are they salted, non-salted?
Roasted and salted.
Roasted and salted. Okay, we shouldn't say who these came from, so we won't mention Liz's name.
Yes, I'm going to berate her later.
Oh, you're going to berate her?
On the salt, yeah.
For being honest?
No
Okay,
salt.
go ahead, Chad.
You want all of it?
So when we go down, so 1 bag is how many ounces?
1 bag is 2 ounces.
And the serving size says?
Serving size is 1.
So half of the bag. Does that give her about 5 cashews maybe, Chad?
Well, the whole bag is 1 serving.
Well, I thought you said 1 serving was 1 ounce.
It's 2 ounces.
Oh, it's 2 ounces, excuse me, so I misunderstood. So the whole bag, she gets 10 cashews. So go ahead, out of these cashews, the caloric intake?
330 calories.
330. Okay, now let's go to the...
Fat calories are 230.
Let's go to the sodium.
Sodium is 230 milligrams.
Oh.
10% of the daily value.
Okay. And then we go to, there are probably no carbs in there.
17 grams.
Okay, and fat? We missed that one up top.
Fat calories 230. Total fat 27 grams.
Ooh, okay. So someone with high blood pressure asking about ethnicity. There has been research showing African American recommendation for sodium is lower. There is a genetic component with our kidneys. More African Americans go on to dialysis, right? Could be they didn't come in, could be they didn't trust the doctor, could be they didn't take their medicines. However, there is a genetic component. So all African American patients, I recommend 1,500 milligrams. Now, in my culture, we've been discriminated all of our lives. The movie Selma's coming out, right? So why would I tell just African American patients 1,500? Does anyone know the average amount of sodium Americans consume in a day? I said 1,500 is recommended for African Americans.
3,500.
3,500 she feels is the average. It's actually 7,000 to 8,000 milligrams a day. So if I tell patients 1,500, I told Hattie this last night, if I get them to cut down from 7,000 to 3,500 by at least reading their cashews that are salted, it's going to help. You told me 230 in that. Okay, and then you had something else back there. Was that a carbohydrate one?
Oh, this is Atkins.
Okay, Atkins.
But look at 240 milligrams of sodium in this Atkins bar.
And then how many carbohydrates?
Carbs should be low. Yeah, 18.
And fat? And any protein? Any protein?
15.
15 grams of protein. It's pretty good. Then I've got a lovely, and how many of us like Nature Valley, courtesy of Bill. Oh, I shouldn't have told. Oats and honey. 16 grams of whole grain. Now, how many of us tell our patients increase fiber, right? So if we do that, serving size is 2 bars, so that's the package. It's got 190 calories, 60 of those from fat. Cholesterol, 0. Sodium, 160. Total carbohydrates, 29 grams. Dietary fiber, 2. Protein, 4 grams. So, if this offers 29 grams of carbohydrates, what do you tell your patients with diabetes per meal? 35 grams. So when that patient brought in her oatmeal, I don't think she had diabetes. I think we were looking at the sodium, but it doesn't matter because I want to prevent diabetes, so I look at calories, and I look at the carbs, and I look at the sodium. And I have my patients pay attention to serving size because the oatmeal might be, and that's why I appreciate Chad, I had to clarify 1 ounce or 2 because cereals might be what? 1/3 cup, 2/3 cup. My husband is 6'4". If he was to eat any cereal, would 2/3 cup be adequate? I mean, really? And his muscles, really, would 2/3 cup? So I explained to the female, who's going to go home to the husband, that what? He probably eats, we need to kind of double or triple that. So if we were to double or triple any of these, we get a lot more. Hence, I'm a well-paid nutritionist, right? Because that's the lifestyle change.
So I think we have one more question, and we have about 4 minutes left. So.
Wait, I just wanted to make a comment that along with that, also wanted to ask you about exercise.
Yes.
And culturally.
Yes.
Like when you don't have the financial means to get bicycles or any other kind of gadget, but you have cultural ways like ballet folklorico or danza.
Excellent question. So we heard that at the beginning, right? Exercise. I encourage my patients what? Just like you. How many minutes of cardiovascular exercise a day?
30.
That's right. And with the 30 minutes, I then ask them well, in fact, it's in our computer, the back office asks how much exercise per day, per week, etc. So with that 30, then what's my next question? Because I like to deep dive and get into people's business, that nosiness, right? Weightlifting. However, what about that cardiovascular though, Patty? Is it just 30 minutes like I'm walking around this room or increase the heart rate? So I ask if they're breaking a sweat. So again, you don't belittle what they're doing, but ask if they're breaking a sweat. How many of my patients do you think say, oh no, doc, I don't break a sweat? Well, then you need to, if you have the exercise equipment, increase the resistance, the incline, the speed. If you don't, most people own a TV, phone, or computer. On DirecTV. I don't know what your cable companies are up here, Cox, whatever they are, right? Are there some exercise shows, right? The abs, the butt burning stuff, all of that. It's on the TV. Right in your home. Yoga in your home. That that over the holidays with my kids, and my boys, my daughter were doing yoga, and the family would move the table out of the way, and we did yoga. Walk. If you don't have 30 consecutive minutes, when else could you walk? Most people probably eat 3 what a day? Breakfast, lunch, and dinner. What if you walk 10 minutes after a meal? That's 30 minutes. Might not break a sweat, however, more weight's coming off. I talked to Hattie last night. If you're in a place where there is the park, you drive to the park or the beach. San Diego's free with all that. And having lived in Ohio and Philadelphia and Maryland, when I'm told it's cold, no, you don't have 10 inches of snow and ice, so no, San Diego's not cold. It's just not cold, and I let them know that. Even though I'm climatized, I let them know it's not cold. So you can walk outside or do the exercises in the house. You do not, and I tell all my patients, you do not have to join a gym. Then does the library have a yoga class? Does the Boys and Girls Club offer something free? A lot of free things, right? Start a neighborhood walk. One at the job. So there are ways, it's giving the patient some strategies and asking them to make a change. Do you drink, 6 Pepsis a day? Well, let's cut back on the soda. You eat chips? No more chips. So great question. Exercise is key, and the smoking and the alcohol. Lifestyles actually, that's why I'm a well-paid nutritionist. Never would have thought I'm a well-paid nutritionist reading food labels. So I pull up 2 sources for you. Beyond Diet and then CalorieKing.com. We have Costco down in San Diego. What do you have? Sam's Club, Costco? You have those hot dogs and the soda and the pizza. Oh boy, that's going to cover a day's worth of food. Oh, a day's worth of calories. I actually, part of the CME, we actually asked this question at the CME for the primary care doctors about the Denny's Grands French toast lamb, how many milligrams of sodium. It doesn't matter, it's over the day's worth, right? It doesn't matter. And then how to adjust medicines, and so some questions like that were presented at that time. So to really bring to the attention, I think one of them, the pizza or the hot dog, I think it's the pizza has like 1,630 milligrams of sodium and the calories, and then CalorieKing.com will tell them how many, like 3 hours of walking, hour and a half of jogging, swimming to burn it off. So I pull that up in the office. Thank you, I went way over, and I do bring gifts coming into your home. So I'm hoping that you can take one thing away, and I hope, literally, I was able to light the way for you. And you can have these in writing, and it's a stylus. So if I could ask Carla to help me, they say San Diego. And so there's unbiased, and they happen to be red, white, and blue. So I think I do have enough for everyone.
Well, very good. This is a great start. Are you available to stay if someone?
Yes, I am. My flight out is later today.
Thank you. That's an excellent presentation, and thank you all for coming out.
Thank you all for your attention.
Please give a round of applause to Dr. Thank you. So to remind you, next month we will be having a meeting to talk about HIE, Health Information Exchange. Mr. David Watson from Health Index has agreed to come and speak with us, and I think it's going to be very interesting as we talk about the importance of health data exchange. Thank you.
I just want to mention to everybody, all the providers in the room, to please fill out. Everybody, please fill out your continuing medical education certificate so you'll be ready here. Thank you, staff, for supporting me.
Thank you. Thank you all for coming and staying. Thank you for volunteering.